I'd like to invite the next speaker. It's Professor Dr. Ishtiaq Rizvi, who is a consultant accident and emergency department in the NHS. And his talk is going to be on acute care, considerations in training of junior doctors, accident emergency doctors. And just to keep things tight, can I just remind people, speakers, the audience, just to time keep, and just to focus on questions as opposed to comments, please. Thank you.
Thank you very much, Mr. Chairman, and Suhail Chughtai, especially for organizing this. And it's an honor for me to be part of this conference today. I'm very conscious of the fact that the time constraints are there, so I'll stick to my 10 minutes, and I'll be very brief and to the point. So, regarding the eligibility of for the training, there are minimum standards which are laid down. Now, previously, what used to happen was that an FY1 would form part of their experience in training going through the emergency medicine. Sorry, that doesn't seem to be the case anymore. We would only take trainees who have at least completed a year of their foundation year, having rotated through different specialties, mainly surgery and one post in medicine, and they would then be accepted as part of their trainee into emergency medicine. The trainee would then be allowed to start or complete as part of their further training in the emergency medicine. What training programs are on offer as far as the training within the emergency department is concerned? One is the ACCS, which is the Acute Care Common STEM pathway. This would involve them rotating through emergency medicine, where they'll be spending part of their placement. It would be in the intensive care unit, in the anesthesia department, and in acute medicine. So usually is over 2 years duration, but it gives a fairly broad base for them to get the knowledge necessary. Then there is core training, as we call the CT training, and that is in medicine and surgery, and this used to be at the senior house officer level, which is the foundation year 2 from now onwards. There is specialty training, and this is for preparing them and going through the general practice, through the peds, obs and gynae, and it should be at a senior level, which is at a registrar, either in a medical or a surgical specialty. It could also include cardiology, a cardiothoracic, or in orthopedics. Then there is a specialty doctor itself. Formerly, they were called the staff grades, and they are the ones who are the backbone as far as the delivery, the service delivery element within the NHS is concerned, and they really do an invaluable job in providing that service within the trusts. Then we lead on to what is the consultant, and I'll expand a little bit on that in emergency medicine, as far as prior to an appointment as an emergency medicine consultant is concerned, they must have passed all parts of their FR Chem exam, which is the Fellowship of the Royal College of Emergency Medicine, and they must have a minimum of in-date courses such as the Advanced Trauma Life Support course, Advanced Life Support course, Advanced Cardiac Life Support course, or one of the pediatric life support courses, as either the Advanced Pediatric or Pediatric Advanced Life Support courses. So this is a kind of standard which is expected whenever the appointment for a consultant post is happening for the junior doctors. Now out goes and gone are the days of cramming, and some of my fellow senior colleagues, as we used to call the cramming or the ratta of a cover to cover of a Gray's Anatomy or a Ganong Physiology, unfortunately is out of date nowadays. In comes learning tools which have replaced, and these are in online tools. The World Wide Web has opened up a completely new world, and it isn't that long that this was introduced, but the uptake is absolutely phenomenal as far as the growth is concerned. And everyone, no matter whether they are in UK, US, Pakistan, or any other part of the world, access is open to them as far as learning goes. CDs, even now the bigger reference books are available in that format, and some of the textbooks now, in fact, when they are being sold, CD forms part of it, and it is at the back cover of those. Planet of the Apps, it's nothing to do with the conference which has the same APPS thing. All the apps are now available on the Android phones, and most people have the iPhones, and you have access to all sorts of things, including within the UK, for example, the British National Formulary, the BNF, is available on the app, so you are on the go and you have access. In fact, they have recently now opened that up to worldwide, so anybody with a phone anywhere in the world can have access to the British National Formulary and update their knowledge and prescribe the medications with safety. From students to medics, gone are the days of the long essays whereby you had to write pages and pages of those, and the answers were weighed and the marks were given accordingly. That doesn't seem to be the case anymore. The assessment tools which are in vogue and in use now are the multiple choice questions, and it gives that degree of objectivity. There are multiple selection questions, and there are short answers. There is problem-based learning available to the students at university and medical college level. And there are tick box exercises whereby it's a computer which picks up what the correct answers are, and it gives you that degree of confidence. Training these days is guideline and protocol driven. So for everything there is a guideline or a protocol that is available, and we are creating a generation of newly experienced doctors who are very much attuned to and tend to follow what is available as a protocol. So for everything they ask for a protocol. National Institute of Health and Clinical Excellence provides these guidelines, whether these are prescribing of drugs, whether these are investigations that are required, whether it is a chemotherapy that needs to be given. All the guidelines are there for us and for the newly qualified doctors to take. The Royal College of Emergency Medicine has guidelines in place for the management of the most of the common conditions that present to the emergency department. So if you need a CT scan, then all you need to do is complete tick boxes. If the patient ticks any of those boxes, you go straight ahead for a CT scan, and no questions asked, no arguments with the consultant radiologist to convince them whether a CT is required or not. You just get on with it. There's a consultant sign-off whereby the trainees are provided with all the support and all the help they need in getting that confidence building as far as treating of the diseases are concerned. So they see the patient, they clog the patient, and then they come to the consultant for getting a final sign-off. Knowledge, skill set, experience gives rise to arousal and helps to improve the performance. Thanks for listening. And any questions? Thank you.
Thank you very much, Professor Ishtiaq. I think we have time for a couple of questions. Anyone? We've got someone in the front row here. Yes.
Do you see any changes in the future of junior doctor training in the emergency department? Future directions?
Yeah, no, thank you very much. What I see as the future of training, it would be from a different angle from what my previous generation is used to. It would not be classroom based. It would be more either a virtual, or it will be on mannequins, and it would be whereby before what I call that the doctors that let loose on their patients, they would have gained plenty of experience in other modes of practicing safely before they are actually allowed to deal with the patients.
Thank you. Any other questions?
Okay.
Thank you very much,
Thank you very much.
Professor Ishtiaq. Thank you for giving us an update